One of the most difficult situations that we need to deal with regarding breast cancer is an uncommon situation where the diagnosis occurs when the patient is pregnant. And for obvious reasons, this is a very difficult situation for everyone involved. There are several dogmas in the management of this situation. One of those dogmas is that if this situation occurs, you must always terminate the pregnancy. And this is far from being correct. So these days we have enough data to tell us that a lot of the treatments that are necessary for the management of breast cancer can be performed during pregnancy. And therefore, although termination is an option that has to be discussed with the patient and the partner, it is not mandatory and it is not the obvious solution most of the time. It is also important to know that terminating the pregnancy does not improve the prognosis. So one fear of the patient is that if she continues the pregnancy, that the changes in the hormonal environment may increase the risk of a bad prognosis or of a relapse. That is not true. So we have enough cases. Obviously, we do not have any randomized trial, but we have enough cases to tell with certainty that continuing the pregnancy does not worsen the prognosis for the mother. Regarding the safety for the child, we also have enough cases to say that surgery can be performed safely, that many of the needed chemotherapy agents can also be given during pregnancy, and I'll come back to that in a minute. And we also know what we should not give. So, for example, endocrine therapy cannot be given during pregnancy. Another important agent for a specific subtype of breast cancer that is called trastuzumab can also not be given during pregnancy. And for radiation, although there is a possibility to give the treatment during pregnancy, there is very rarely the need to do so, and so usually it's recommended that we wait for delivery. So when the diagnosis occurs very early in the pregnancy, so let's say the first trimester, the situation is more difficult because there is no chemotherapy that you can prescribe. So what can we do in those situations? If the tumor is small enough, we can start with surgery. And surgery can usually be done without any contraindication. And we can save the chemotherapy to give after surgery when the pregnancy is already in the second trimester. So second and third trimester, chemotherapy is safe. We cannot use all the agents available, but for those who are used for the treatment of breast cancer, and the most important ones, such as anthracyclines and taxanes, we can indeed give them during the pregnancy. The most important message is to avoid an early delivery. What we also know very clearly is that what is worst for the baby is to be premature. A lot of the problems for these children arise from the fact that very often people speed after delivery and the baby is premature and has all the problems, physical and mental, associated with the premature delivery. So what we recommend these days is that do not deliver the baby before the week 37, unless obviously there is an emergency situation either for the mother or for the child. So very often you start with surgery, you do the chemotherapy, and when it's time to deliver, naturally, there is the delivery and you continue and finish treatment after delivery. Some situation where the diagnosis is made already in the second trimester and the tumor is bigger, you can start with chemotherapy and then do the surgery afterwards. So there is very little that you have to adapt to the treatment of the breast cancer because the lady is pregnant. So the goal is always to provide the best available treatment for the cancer diagnosed, while at the same time safeguarding the child. And it's very much possible to have both mother and child well at the end of the pregnancy.